Good morning, everyone. This is Dipanjali De, first year postgraduate student from the Department of Periodontology, and today I will be continuing with part 2 of my seminar, Influences of Systemic Conditions on the Periodontium. And today I will be discussing in detail the endocrine disorders, that is, diabetes mellitus, female sex hormone disorders, and hyperparathyroidism. According to the definition given in Harrison's, diabetes is clinically and genetically heterogeneous group of metabolic disorders manifested by abnormally high levels of glucose in the blood. According to the American Diabetes Association, the chronic hyperglycemia of diabetes is associated with long-term damage, dysfunction, and failure of various organs, including the eyes, kidneys, nerves, heart, and blood vessels. Diabetes may be classified as type 1 diabetes, formerly known as insulin dependent diabetes, type 2 diabetes, formerly known as non-insulin dependent diabetes, gestational diabetes, and other types of rare diabetes such as genetic defects in beta cell function, genetic defects in insulin action, diabetes due to infections, or drug-induced diabetes, among others. In this seminar, I will be discussing in detail mainly type 1 and type 2 diabetes. Now, how does diabetes occur? In the case of type 1 diabetes, due to autoimmune destruction of the insulin producing beta cells of the islets of Langerhans of the pancreas, very little to no insulin is produced in the body. Due to the absence of insulin production, glucose cannot be taken up by the cells and hyperglycemia ensues. In the case of type 2 diabetes, it is characterized by peripheral resistance to insulin, impaired insulin secretion, or increased glucose production by the liver, which again leads to reduced uptake of glucose and hyperglycemia. Now, this hyperglycemia may be either intracellular or extracellular. Intracellular hyperglycemia may cause neoglucogenesis and glycogenolysis, causing the breakdown of fats and proteins. Breakdown of proteins causes cachexia, lethargy, and polyphagia, decreased synthesis of gamma globulins, susceptibility to infections, and impaired wound healing. The breakdown of fats cause high levels of ketone accumulation in the blood, which may lead to diabetic ketoacidosis. In case of extracellular hyperglycemia, the blood glucose level may cross the renal threshold and glucosuria may occur, which may lead to osmotic diuresis with the symptoms of polyuria, polydipsia, hypokalemia, and hyponatremia. Extracellular hyperglycemia may also cause hyperosmotic plasma, leading to the dehydration of cells and a hyperglycemic coma. Moving on to the symptoms of type 1 and type 2 diabetes, there is strong overlap between the two, which involves polyuria, weakness, visual impairment, and frequent infections, but there are also several differences between these two types of diabetes. The onset for type 1 diabetes is usually young, generally less than 30 years of age, which is why it is also known as juvenile diabetes, while type 2 diabetes is usually seen in adulthood. Individuals having type 1 diabetes are usually of normal or thin stature and mostly white, whereas people who have type 2 diabetes are generally obese and of the African American, Hispanic, or American Indian races. Family history is common in both, but more common with type 2 diabetes. Clinical onset is abrupt for type 1 and slow for type 2. The pathogenesis, as I had mentioned earlier, for type 1 is autoimmune beta cell destruction, and for type 2 is insulin resistance, impaired secretion, or increased liver glucose production. Endogenous insulin production for type 1 is little to none, and for type 2 it may be decreased, normal, or even in certain cases elevated. There is high susceptibility to ketoacidosis in type 1, low for type 2, and treatment for both includes diet, exercise, and insulin, but oral agents may also be used in type 2 diabetes. The classic complications of diabetes can include microvascular and microvascular diseases. The microvascular symptoms involve retinopathy, nephropathy, and neuropathy. Macrovascular involves peripheral vascular disease, cardiovascular disease, and cerebral vascular diseases. There is altered wound healing seen, and the sixth complication is periodontal disease. Oral manifestations of diabetes mellitus have been reported, such as stomatitis, benign migratory glossitis, fissured tongue, and lichen planus, among others. The oral changes that may be seen involve chiliosis, mucosal drying and cracking, burning mouth and tongue, diminished salivary flow, among others, and the specific periodontal changes that are seen include enlarged gingiva, sessile or pedunculated gingival polyps, polypoid gingival proliferations, abscess formations, and loosened teeth and periodontitis. These are certain images showing benign migratory glossitis and oral lichen planus in patients having diabetes. Delayed mucosal wound healing, mucosensory disorders, dental caries and tooth loss have also been reported. Xerostomia is also seen in such patients, mostly in diabetes rather than the controls, especially in those who had developed neuropathy. Candidiasis is more prevalent in patients with diabetes, especially in those who have smoke, wear dentures, have very poor glycemic control, and use steroids and broad spectrum antibiotics. There is also increased chances of these patients developing localized osteitis. There is delayed vascularization, reduced blood flow, a decline in innate immunity, decreased growth factor production, and psychological stress involved in the protracted wound healing of the oral cavity mucosa. These are certain images that show dry socket or alveolar osteitis and oral candidiasis in diabetic patients. Burning mouth syndrome is also seen in diabetics, whose underlying cause could be diabetic neuropathy. The nerve damage in diabetic neuropathy has been reported to show an increase in Langerhans cells associated with immune disturbance. Again, as I had mentioned, periodontitis is the sixth complication of diabetes mellitus, where changes in the collagen state altered immune function, causing impairment of the polymorphonuclear leukocyte function is seen. There is accumulation of advanced glycation end products, which results from prolonged and chronic hyperglycemia and increased secretion of pro-inflammatory cytokines such as tumor necrosis factor alpha and prostaglandin E2. This all results in compromised wound healing as well as periodontal tissue destruction. Diabetes carries 2 to 3 times higher risk for both severe periodontitis and the incidence of periodontal disease progression. These are images showing panoramic and intraoral periapical radiographs of a poorly controlled diabetic patient showing severe bone loss. Now, how does diabetes actually affect and cause periodontitis? Usually due to increased hyperglycemia, there is glycosylation of proteins, lipids, and nucleic acids, causing the formation and accumulation of advanced glycation products, also known as AGEs. These AGEs, they form on the collagen and cause increased collagen cross-linking, causing collagen to become highly stable and resist normal degradation and turnover. AGEs also interact with the receptors, which are known as receptors for AGEs, also known as RAGs or RAGE. This age-RAGE interaction causes increased release of cytokines and pro-inflammatory factors such as interleukin 6, TNF-alpha among others, which cause an exaggerated response to periodontal pathogens and cause accelerated destruction of non-mineralized connective tissue and bone in diabetes. This is a flowchart showing how diabetes can lead to periodontal disease progression through many pathways, such as through degenerative vascular changes, formation of AGEs that I had just explained, altered cellular response leading to the decreased chemotaxis, decreased adherence, and decreased phagocytosis of polymorphonucleosides, increased release of pro-inflammatory factors, decreased oxygen utilization, and decreased polymorphonucleoside migration. Moving on to the female sex hormones. Under the broad category of dental plaque-induced gingival diseases that are modified by systemic factors, those associated with the endocrine system can be classified as puberty, menstrual cycle, or pregnancy-associated gingivitis. In 1999, the International Workshop Classification for Periodontal Diseases had a section specifically on female sex steroid hormones, which is shown in the chart on the right side. Although androgens can also play a role in modulating periodontal tissue responses, main sex steroids which show evidence for this are the estrogens and the progestins. These female sex hormones by themselves are neither necessary nor sufficient to produce gingival changes, but they may alter the periodontal tissue responses to microbial plaque and thus indirectly contribute to periodontal disease. During puberty, there is a dramatic rise in female sex steroid levels during the circumpubertal period, increase in the gingival inflammation without an accompanying increase in plaque levels. This gingivitis manifests as marginal and interdental gingival enlargement, found primarily on the facial surfaces, with the lingual surfaces remaining relatively unaltered. Microbial changes are seen, primarily Prevotella intermedia is seen predominantly in these conditions. Although the prevalence and severity of gingival disease are increased during puberty, gingivitis is not a universal occurrence for all adolescents. During menstruation, gingival manifestations of bleeding and swollen gingiva are seen. There is an increase in the gingival exudate, most pronounced in the presence of pre-existing gingivitis, and minor increases in tooth mobility have also been reported. The exudate from the inflamed gingiva increases during menstruation, suggesting that pre-existing gingivitis is aggravated by it. However, the clavicular fluid of a normal healthy gingiva remains unaffected. In addition to this inflammation, intraoral recurrent aphthous ulcers, herpes labialis lesions, and candidal infections have also been documented in certain women and is associated with increased progesterone levels during the reproductive cycle. Now, during pregnancy, gingival inflammatory changes usually begin during the second month and increase in severity throughout the 8th month, after which there is an abrupt decrease related to a reduction in the levels of the sex hormones. The greatest involvement appears to be in the anterior areas of the oral cavity, with the interproximal sites most commonly being affected. Other changes that are seen show increased gingival probing depths, increased bleeding upon probing or mechanical stimulation, and increased gingival clavicular fluid flow and increased mobility. Pre-existing gingivitis or periodontitis has been noted to worsen dramatically, but attachment levels, however, remain unaffected. 0.5 to 9.6% of women who are pregnant also experience localized gingival enlargement consistent with pyogenic granulomas, which are also known as pregnancy tumors. These lesions have been described as painless exophytic masses which either have a sessile or pedunculated base extending from the gingival margin or in certain cases from the interproximal tissues in the maxillary anterior region. This tumor develops as a result of exaggerated inflammatory response to irritation, mostly calculus. It enlarges rapidly, bleeds easily, and may range in color from purplish red to deep blue. The gingiva is involved in 70% of the cases, followed by involvement of the tongue, the lips, and the buccal mucosa. Following parturition, the lesion usually regresses completely. During menopause, estradiol ceases to be the major circulating estrogen hormone, and estrone, which lacks cyclic influence, predominates. Sex steroid-induced gingival inflammatory changes witnessed during the reproductive years no longer occur to any degree. Instead, menopausal gingivostomatitis may develop, characterized by gingival tissues that are shiny and dry, bleed easily, and may range in color from pale to erythematous. In addition to gingival changes, reduced estrogen levels certainly may impact overall collagen metabolism, including the bone maintenance. Moving on to hyperparathyroidism, it is a condition in which one or more of the parathyroid glands become overactive and secrete too much of the parathyroid hormone. This causes the levels of calcium in the blood to rise, a condition known as hypercalcemia. This hypersecretion causes increased hypercalcemia following generalized demineralization of the skeleton, increased osteoclasis with proliferation of the connective tissue in the enlarged marrow spaces, and formation of bone cysts and giant cell tumors. These bone cysts become filled with fibrous tissue having abundant hemosiderin-laden macrophages and giant cells. These cysts have been called brown tumors, although they are actually reparative giant cell granulomas. Oral changes that may be seen during this time include malocclusion and tooth mobility, radiographic evidence of alveolar osteoporosis with closely meshed trabeculae, widening of the periodontal ligament space, absence of lamina dura, and radiolucent cyst-like spaces. This concludes my part 2 of influences of systemic conditions on the periodontium. In the part 3, I will be discussing the hematological and immunodeficiency disorders. Thank you.